أهلا وسهلا بكم في لقائنا مجددا في منتدى الثقافة في بريطانيا، وأرحب ويسرني أن أرحب بالدكتورة غادة سلمان، استشارية الطب النسائية والتوليد في بريطانيا. Ladies and gentlemen, thank you for joining us today in Arabic Cultural Forum in United Kingdom, and I am pleased to welcome Dr. غادة سلمان, consultant gynecologist in UK. Just a brief introduction to Dr. غادة سلمان. She is a consultant gynecologist, as I said, with main interest and special skills in minimal invasive surgery, early pregnancy, and gynecological imaging. Following completion of her training in Northwest Thames, London, including registrar post at the Queen's, Charlotte and Chelsea and Westminster hospitals, غادة was appointed as a consultant gynecologist at UCLH in 2011. Subsequently, Dr. Salman completed a master's degree, MSc in ultrasound of gynecology and early pregnancy at King's College London. In 2013, she was awarded a fellowship of the Royal College of Obstetricians and Gynecologists in London, and that was in 2017. Ms. Salman is an active committee member of the British Society for Gynecological Imaging, BSGI, and has published and presented her work on pregnancy, gynecology, ultrasound, and endoscopic gynecology, both nationally and internationally. And she's also the author of numerous scientific chapters and papers in her field, the field of her specialty. So welcome, Dr. غادة سلمان. أهلا وسهلا.
Thank you so much. Thank you. Shukran,
Your today is about endometriosis. The platform is yours.
Thank you so much, Dr. Amr, and thank you so much for inviting me to present about endometriosis. It's a pleasure to be with you all, and we will try and make this lecture as simple as possible, so for everyone to participate and share, and I'll be very happy to take any questions at the end. So I'm just going to start by sharing now.
Yeah.
Perfect. So we are going to talk about endometriosis, the symptoms, treatments, and myths. So what is endometriosis? And I thought before I start presenting in a medical term, we will see if that will work, listening to this short video from the BBC.
The doctor said that I was making my pain up so I could miss school. Just got told I had heavy periods.
When I go to A&E, they think that I might be a drug addict.
It's taken me 11 years to finally get a diagnosis.
And they were telling me that I was making it up.
It just makes you feel like giving up. If a man went in and said, I feel like my testicles falling off, it'd probably get taken quite seriously.
Endometriosis is a condition that affects women whereby cells, a bit like those in the lining of the womb, are found outside of the womb. They bleed and they cause inflammation, and this in turn can lead to often very debilitating pain. It's estimated that 1 in 10 women suffer from endometriosis, so that makes this condition as common as diabetes.
My pain feels like I have sat on a hot knife.
Putting the hand up inside you and just like squeezing all your organs.
Like someone's getting a knife and just whipping it around on the inside.
I can't wear tampons because they're too painful.
There have been times I've vomited just because it's just so much on my body.
Being misdiagnosed made me feel
angry,
alone,
really sad,
confused,
helpless.
Nobody believed me.
Endometriosis is hard to diagnose because there's a little limited awareness about the condition, so we still don't fully understand what causes the condition, how and why it develops.
I got told I had polycystic ovary syndrome.
I had IBS.
Irritable bowel disease.
Over 11 years, I've been hospitalised, maybe 50 times.
I've seen doctors that have never heard of it.
It's also difficult to diagnose because it mimics other conditions like irritable bowel syndrome, for example. I think the major problem is that we don't have a simple test, and the main way of diagnosing it is by having keyhole surgery. This is a burden for women. It's a cost to the health services, but it also has sometimes complications. So it's not something that we would want to rush into. In the UK, sadly, at the moment, anything between 7 to 8 years is the delay in the diagnosis for endometriosis.
It's 10 years of the same symptoms just getting progressively worse and no real investigation as to why.
16 years, and it's only sort of been in the last 12 months that they've mentioned this condition. I've seen in the region of about 50 doctors.
This year, 5 times that I've been in hospital, been in A&E because of pain.
It makes me feel angry, but it also makes me feel worried about all the other women out there that are currently struggling.
There's definitely some evidence that there's a gender pain gap, if you like. Historically, women's health research has suffered largely because men have been making decisions about which conditions to give limited research funding to. People didn't talk about things like period pain, which is obviously a major symptom of the condition.
I think society doesn't take women's pain as serious as they should. A lot of the time I've gone to doctors and been like, I'm having pain about my periods.
They shouldn't talk about it, it's not that bad.
Everyone bleeds heavily, that's what happens.
Women, they get pain, that's just how it is.
Collapsing the street and going to a hospital in an ambulance isn't part of being a woman.
So I think listening to these women give us an idea of how bad is endometriosis and how painful is this condition. So if we try and explain more about it, what is endometriosis? So endometriosis is a condition where endometrial tissue, that is the tissue that normally lines the inside of the womb or of the uterus, grows outside the uterus in areas such as the ovaries or the pelvis. And because they are similar to the cells that are inside the lining of the womb, they are similar to that, will respond to hormones, and they will bleed every month, similar to periods, causing inflammation and scar tissue formation in these organs. It is one of the most common gynecological disease needing treatment, and it's mainly a disease of reproductive years. And although the exact cause of it is unknown, it is hormone mediated. So it is associated with menstruation. And the main symptoms that it causes, as you heard to these women, is pelvic pain, painful periods, and subfertility. So how common is endometriosis? Is it common or is it not? Actually, looking at the figures, the exact prevalence is not very well known because obviously some women will have endometriosis without showing any symptoms, but in general, it is estimated to be between 2 to 10% of the general female population and about 1% of the women of reproductive age, that's between puberty and menopause. And about 10% of women worldwide have endometriosis, and that's about 176 million. And in UK alone is 1.5 million of women suffers with endometriosis. So it's a large proportion of women do suffer from this condition. And women with infertility, 50% of them will have endometriosis. It is the second most common gynecological condition. And on average, it takes 7 to 8 years from the onset of symptoms to get diagnosis. And that's what we are going to kind of talk about more during this talk. So what causes endometriosis? Do we know? Again, the exact cause, and that's the problem, is not very well known. It is not clear whether endometriosis is progressive, that means starts from mild and becomes severe, or just remains stable or improve with time. We still don't know. But what we know is a multifactorial, is a complex disease. And it may be linked to genetics or even environmental toxins. So certain genes, certain toxins might be predisposed these women to develop the disease, but also it tends to run in families. So from a family history of endometriosis, women who have a higher risk of developing this condition if their mother or their sister has also been affected. And there are so many theories that have been proposed, although no one theory has been scientifically proven. And I'm just going to talk about a few of these theories. And the most common one is the retrograde menstruation. That means some of the menstrual blood during the period flows back through the fallopian tubes into the pelvic cavity and embed itself onto the organ of the pelvis. Or that the menstrual blood can leak into the pelvis cavity or the pelvic cavity through a surgical scar, such as the cesarean section delivery scar. The other theory suggests actually these cells might transport out of the uterus using the lymphatic system. While a third theory suggested what's called the Mullerian theory, suggested that the endometriosis starts very early in the embryonic or fetal period, with these cells being misplaced into the pelvis, and they would start to respond to hormones at puberty. And another theory suggested actually these cells, they are normal to start with, but they change, they transform into an endometrial cell gradually or because of a certain cause. And then they again start responding to hormones and become similar to endometriotic cells. Another theory suggests it is actually immunological, that there are some faulty immune system that is not destroying the wrong cells. And the sixth theory suggested it's a hormonal cause. That means these hormones transform these cells outside the uterus to become an endometrial cells, and they will bleed during the menstrual cycle, causing this condition. So there are still so many theories that we are not sure of. So if that is the case, then where it is located? So it actually could locate anywhere. So it could locate on the surface of the uterus, of the bladder, of the bowel, of the appendix, of the pelvis itself, the peritoneum, everywhere, even on the umbilicus. So it can reach even up to the diaphragm, depending on why it happened and what theory it's following. So if you look at all the organs, we can find it in the ovaries, in the surface of organs, between the bowel, the appendix, the bladder, the umbilicus, the cesarean section scar, and in rare cases, it can be found on the diaphragm and even in the lungs. So who is affected by this condition? Actually, anyone, any of the women of any age can be affected, but usually it presents between the age of 15 to 49 is the age of reproductive years. But endometriosis can start as early as the girl's first period. The condition can actually begin at any age, although it's rare to begin before the puberty as the disorder reacts to hormones. And if that's the fact, the symptoms usually will settle after the menopause. Doesn't completely resolve, but in most of the time it settles. So what does it look like? So all these are images from a laparoscopy of endometriosis patients. And you can see how it is. So this is endometriosis. So it can found anywhere on the ovaries, on the bladder, on the bowel, everywhere. So the American Society for Reproductive Medicine actually looked into staging this condition, and they staged it from stage 1 to stage 4. Stage 1 being minimal, that means there is few isolated superficial implants, and stage 2 being mild, where there are several implants of this tissue that are slightly more deep embedded. Then stage 3, where there are many deep implants on one or both ovaries, small cysts, or there are fibrous tissue. And the stage 4, when it is severe and there's deep implants that are on the ovaries, a large cyst, dense adhesions, and that is a very, very difficult disease to treat if it reaches this stage. So what it can cause? What are the signs and symptoms? So because it grows anywhere and everywhere, it actually can cause a lot of symptoms, ranging from its effect on the ovaries, on the pelvis, on the bowel, on the bladder. And the symptoms may vary from woman to woman. So some women might have no symptoms, while others will have significantly painful symptoms. And you heard these women, how painful it was for them. How did they suffer years and years of this condition? Can be acute, the pain, or can be chronic. And it can really adversely affect the woman's quality of life, ability to work, ability to have relations with their partners, their families, even work. And again, depending on where it grows, the symptoms can include even pain in the back, pain in the leg, in the chest. So pain can be everywhere. And also the woman who had a previous cesarean section can have a pain in their scar or a lump in the area. And because it's so variable, these symptoms can have a major impact on different aspects of individuals' life, from their personal life to their social life to the work. So if we just put few of the symptoms that it can cause, and it can cause even more than that. So between irregular bleeding, chronic pain, painful periods, painful intercourse, painful bowel movement, feeling sick, faint during period, pain on urination, chronic fatigue because they are in pain so much and they are not able to rest or sleep, depression, premenstrual symptoms, pain in the legs, in the chest, painful at the cesarean section, subfertility or infertility is very important, bloatedness, and the symptoms continue. And that's why both nationally and internationally, all the organizations are putting some guidance into how we can diagnose and manage this chronic painful condition. And one of them is NICE, which is National Institute for Health and Care Excellence. So how can we diagnose this condition? It is not easy. And that's why the diagnosis of endometriosis can take around 7 to 8 years on average, and sometimes even a delay up to 12 years from the onset of symptoms to receiving the definite diagnosis and starting treatment. And you can imagine during all these years, women will suffer a lot. And also because these symptoms can be vague, as we heard, they can be related to other conditions such as irritable bowel syndrome, urinary tract infection or disorder, period pains, especially in young women, or telling them that just a period pain. So it's really, really important when we see these women is to take detailed history, to note the symptoms very accurately and to inquire about any personal or family history, to do examination, to feel for any lumps, any pain, any tenderness, any nodules or lumps or lesions, but also to do some sort of imaging. And when we say imaging, there are two main types of imaging, which is ultrasound is the first one, and the second is MRI or magnetic resonant imaging. And usually with MRI, it is the second option because ultrasound is usually readily available, it's easy, accessible, and you can get a lot of information from it because you are scanning the patient in clinic most of the time. And the top pictures shows how we can see endometriosis by scanning. These couple of pictures are from our unit, scanning patients with endometriosis. But if there is ultrasound that is not available or not enough skills, then obviously MRI will be another option to look for that. If both are not possible or not easy or not clear, then obviously the gold standard is laparoscopy or keyhole surgery to look into that, into the pelvis, to check for cysts, for any bleeding spots, for endometriotic tissue. And that's what we can see on laparoscopy when we see all this scar tissue, all these bleeding areas, and endometriosis on organs. So how can we treat this condition? The treatment can range from simple painkillers to as severe as big surgery. And that will all depend on the symptoms, on the of the patient wish, and also her fertility plans. So at the moment, there is not really a complete cure because we don't know the cause. So we can't completely cure the condition, but we can help if we can diagnose the condition early and if we start treatment option that help to calm this condition down and give the patients the relief from their suffering and their pain. And this management can range from pharmacological to non-pharmacological to surgical treatment. And we know it is estrogen dependent, it's hormone dependent. So most of these medication helps by suppressing the ovarian function, and obviously at the same time are contraceptive. But surgical treatment is always there to help if the endometriosis is severe by destroying these lesions or by resecting them, removing them. And as we said, it will all depend on the woman's symptoms, the preference, priorities, and fertility, as well as the stage of endometriosis. So we can range from conservative, especially if the woman is, planning to get pregnant for fertility, to more radical, okay, when the endometriosis is severe and the woman is suffering with major pains. Analgesia is painkillers, so paracetamol, non-steroidals such as ibuprofen, naproxen. So painkillers is usually very useful as a first step, because pain is the most debilitating symptoms of endometriosis, and that's how we need to treat to start with. Then we can move to hormonal, as we said, because it's hormone dependent. Then we can give hormones to suppress ovarian function and help with suppressing or slowing down of the growth of this tissue and preventing new tissue of growing. We know that it is effective in treating endometriosis, but also we need to know and to tell the patient that they have side effects because it's a hormonal treatment. There are so many types of hormones that can be used, from oral to injections, to implant, to coils, and basically the main component of it is progesterone or other hormones that suppresses estrogen. And that again can be discussed with the patient and offered depending on her condition and her wish. Surgery, it is there and it is useful, and it is basically done in a special or a specialized center where there is a gynecologist with a training and a skill in minimal access surgery or in keyhole or laparoscopic surgery for endometriosis, and in a multidisciplinary approach. That means other specialists are around, including the colorectal, which is the bowel surgeon, urologist, the bladder and ureter doctor, because these patients, some of them will need big operations, and we need the teamwork from all these doctors to help remove this endometriotic tissue. It is usually for severe endometriosis, and we can remove either small spots of endometriosis or cysts from the ovary to larger operation where we remove the whole ovaries, the uterus or the womb, even part of the bowel are sometimes considered. So how can women cope with endometriosis? So yes, medication is one way, but also we looked in other options of how we can help. Maybe diet, exercise, managing stress, alternative therapy. So all of these factors or options have been looked at over the years to see how we can help women with endometriosis. So although we talked about medication as it's the big part and the main part of the treatment, but also some studies or papers looked into complementary therapies. So they found that some women found therapies outside of medicine has helped them, especially with a special or specialist lifestyle intervention, such as diet and exercise. And they found that it can improve their symptoms. And there are so many studies looking into selected food, into the dietary component of the meals, and they linked that to how useful it was in treating endometriosis. So in summary, what they found that a link has been shown between diet that are low in fruits and vegetables and high in red meat and the development of endometriosis. And actually a higher intake of fresh fruit and green vegetable has reduced the relative risk by 40%. Yes, there are not many studies, but there are some studies to show that even changing diet can help. And cutting down on red meat and other meat that can help with reducing the symptoms or the risk of endometriosis. Also, they found omega-3 is very useful and the women who their diet such as was rich in fish, salmon, walnut, flaxseed, they had a lower risk of developing endometriosis. And why is that? Because they think that eating the right food can give protection because of the influence on inflammation, estrogen activity, and other things. And also they found that certain pesticide or insecticides that can be ingested through certain through certain food can be associated with the risk of endometriosis. So there are so many studies going. None of them is kind of have got really very high evidence on, but there is some promising evidence. Also, we looked into the evidence of diet, apart from diet, about exercise. And they found that actually the exercises can be very helpful because it encourages the circulation of blood to these organs, can improve the nutrient oxygen flow, can decrease estrogen production, can reduce stress, and release endorphin in the brain, which is what all we know is a pain relieving chemicals. So again, exercise proved to be useful. And they found that women who regularly exercise can have less chance of developing endometriosis, and also if they engage in high intensity physical activity such as running, swimming, biking, then was surprisingly to find that 75% less likely to develop endometriosis than women who actually do not participate in regular activities. Also the low intensity exercise. So, you don't have to do high intensity exercise. Even yoga can sometimes help by providing some relief for endometriosis. Studies also looked into stress and looked into complementary therapy. And they found actually reducing stress level can help because endometriosis is a high stress due to the impact on life in general. And stress can be exacerbated by endometriosis, but also endometriosis symptoms can also be aggravated by stress. So it's like a vicious cycle. And if we are able to reduce the stress by using some relaxation technique, increase awareness of the body, and refocus on calming activities, then we might be able to reduce the activity of stress hormones. Also, at present, there is not enough evidence or research to support alternative therapy. So we can't say they are useful. We don't have evidence, especially about using Chinese herbal medicine or other alternative therapy. But there are some studies that looked into acupuncture and into other things, and they thought, or they think that acupuncture could help women with endometriosis because it's interfered with pain pathways. Some physiotherapy can help. Chinese herbal medicine maybe can help, but as I said, there's no evidence in the literature that it is useful, but some women might find it useful because of its anti-inflammatory effect. And also vitamins and dietary supplements such as vitamin D that could have an effect, and other components such as vitamin A, vitamin C, because of their antioxidant activity. So more research is needed to look into all these alternative therapies. So why endometriosis is such a difficult disease to understand? Because we don't know why it happens and how it progresses. So there is a lot of myths and facts that kind of rotates around it. And because it's a chronic condition. So that's why it's surrounded by taboos, by myths, by delayed diagnosis, by inconsistent treatment. And for many, this is very frustrating, difficult to understand. Women don't understand it. Maybe healthcare providers don't understand it. But there are some facts now on endometriosis that found on reliable websites, especially endometriosis societies and others, that women can go and look and check and understand. So some of the myths, I'm not going through a lot, but it's about severe pains. Severe period pains are normal. And this is a big myth, especially for young women. They have severe period pain, we say, yes, it's normal. It's not. So what they are told is all in their head, that they have low pain threshold, that you have psychological issue. It's completely untrue. If pain is bad enough to interfere with this girl going to school, with her day-to-day life activities, it is not normal. And we have to investigate to determine the cause of the pain. Also, a myth about that you are too young to have endometriosis. So if someone comes and they're 16 or 17 or even younger, and the healthcare providers will tell them, oh, you are very young, it's unlikely you have endometriosis, or you don't have endometriosis. This is not true. This is a myth, because in fact, endometriosis can be found in teenager, in young women, and they can start as the start of the first period. So we have to look into the symptoms and be aware of it. Another myth is that pregnancy cures endometriosis. Pregnancy doesn't cure endometriosis, but because pregnancy has got high level of progesterone, so it's like any hormonal treatment, it suppresses endometriosis during the course of pregnancy, but the symptoms will recur after the birth of the child. And the symptoms might be delayed by breastfeeding, but it doesn't completely resolve the symptoms because the condition is still there. It has just settled because of the hormones of the pregnancy. And a lot of these women will experience recurrence of their disease and symptoms after. Another very important myth that if you have endometriosis means infertility. And again, this is a big no, because in fact, most women, maybe 3/4 or less of women will be fertile, but the likelihood of fertility problem increases with endometriosis, especially with severe condition. So yes, there is association, but it doesn't mean that every woman who has endometriosis is infertile. And another myth is that if you remove the uterus, we cure endometriosis. Again, this is not correct, because endometriosis is the growth of tissue outside the uterus. So even if you remove the uterus, it doesn't mean that you are removing the extra tissue outside that's causing the symptoms. And there is more and more myths to come. So what is important for all of us as doctors and public is to actually increase awareness of this condition. And that's what BBC's done during the endometriosis awareness campaign. And that's the video that I showed initially. But actually, they've asked 13,500 women who have taken part in their research, revealing the devastating effect of endometriosis. And women who answered the question showed that actually 50% or half of them had suicidal thoughts. And some of them became very highly addictive on painkillers. And most said that this condition has affected their life, education, career, and relationship. And that's when the campaign is becoming more and more big to tell all women that actually it is there, and to tell doctors, to tell public, it is a condition that is affecting women's life, and we need to do something about it. And if you look into all these women, how the endometriosis is affecting them, you can see how the doctors, how the patients can be missed by doctors treating or diagnosing them. This woman for 17 years before she got diagnosed. And we listened to these women, we heard their stories, we know it's happening, and doctors and partners and families are now more aware of this painful chronic condition. So it is a general lack of awareness, actually not only by the doctors and by the public, but it's by the woman herself, because she doesn't really know what these symptoms are. And the rise now in social media, in TVs, in programs, in papers published, in us talking to these women about their symptoms, that they become more aware of it, and the diagnosis and the treatment becomes available. And there is always now more guidance for the doctors. And we can always hear about stories of women not being diagnosed early, or how long it takes for them to get treated. And it's true, it's a delay in diagnosis and treatment. So we need to get these information to public. We need to start from as early as schools, informing teenagers, informing school nurses, putting posters in public toilets, in GP, which is general practitioner clinics, in doctors' clinics, And we educate women, educate girls about the signs and symptoms of endometriosis and how early to seek help so that we stop the progression of this painful, horrible disease. And that's me writing an article about endometriosis and in the Endometriosis Awareness Month in March that had so many reads and comments, because this condition is so important and there are so many women suffering with it. And they were glad to see that there are people who are listening and trying to help. And as we said, there are more and more research happening every day. In conclusion, what I wanted to say is endometriosis is a chronic condition that can impact women's physical, mental, and social well-being and can potentially affect their fertility, their education, and career. And the key is to access early diagnosis. And that should not be hindered by myths or misconception. And the aim is always to improve the quality of these women by enabling them to manage pain and fatigue and reduce the negative impact on their physical and emotional well-being, but also to increase the awareness for early diagnosis and treatment. And there is always still a requirement for improved medical evidence and research surrounding endometriosis until we get the right treatment for these women and stop their suffering. And this is some further information and resources if anyone wants to read more about endometriosis. And thank you so much for listening.
Thank you, Dr. غادة, and much appreciated for your presentation. Very informative lecture and informative presentation. بالعربي طبعا الأخوة الحضور، أنا أرحب بكم جميعا، الأخوات والأخوة الحضور، وخاصة الأخوة من البلدان خارج بريطانيا، فأهلا وسهلا بكم، والأعضاء الجدد لمنتدى الثقافة. ممكن الأسئلة توجه باللغتين العربية أو الإنجليزية للدكتورة غادة سلمان في هذا الموضوع المهم، وهذا هو الحقيقة هو الهدف، وهدفنا التوعية الصحية في مثل هذه المواضيع. وكما ذكرت الدكتورة غادة هذا الموضوع هو موضوع شائع ومرض شائع وحالات أعراض شائعة بين الأعمار، من أعمار المتوسطة قد تكون والمدارس الإعدادية إلى أي عمر قد تكون فيه المرأة قبل سن اليأس، وهذه واحدة من الحالات المعروفة، وتشخيصها قد يكون أيضا صعب وتعرض على المرأة بآلام في منطقة البطن، وهذه الآلام قد تكون مزمنة ومزعجة وتستوجب التدخل العلاجي وتستوجب قبل ذلك التشخيص. طبعا الأسئلة مفتوحة، باب الأسئلة مفتوح لكم حضرات الأخوة والأخوات. أنا عندي سؤال دكتورة غادة، قد أوجه هذا السؤال باللغة العربية وأنت جاوبيني بالعربي أو بالإنجليزي. أنه الكوفيد 19 الكورونا التي بدأت منذ بدايات العام الماضي، عانى الكثير من الناس والكثيرات من النساء بالذات من أعراض الكورونا طويلة الأمد أو اللونج كوفيد، وما ذكرتيه من أعراض بالأبدومينال بين، الفتيج، وقد يتزامن أو قد يتشابه مع حالات الاندومتريوسيس. فهنا يعني واحدة من الديفرنشال دايجنوزز أو التشخيص التفريقي لنا نحن الأطباء في مجالات تشخيص الأمراض أو الأعراض المرضية التي تعرض للمرأة، هو التفريق بين هذه الحالة، حالات اللونج كوفيد وحالات الاندومتريوسيس. ما رأيك بالموضوع؟
Thank you. Yes, absolutely, I agree with you. طبعا أكيد هي شفنا حالات كثيرة في يعني نساء أو رجال صار عندهم مشاكل في الأوجاع، خصوصا أوجاع البطن abdominal pain بعد الكوفيد. With endometriosis طبعا it's mainly for women and of reproductive age, but also they've been suffering most likely before COVID, يعني started before COVID, so we know that it's not related to COVID. But طبعا with COVID we saw this, and because COVID is an inflammation, that's what they found, it causes inflammation, so it can inflame the bowel mucosa the lining, it can inflame, other organs. So it can give very similar symptoms, as you suggested kindly. It's very similar to endometriosis. But with endometriosis, it's sometimes difficult to tell the difference. But if we go back, most of these women will have these symptoms long before COVID, and they've been suffering, maybe with years and months before. So that may be a way to help. But I completely agree with you. We've seen a lot of women with abdominal pain after COVID, and a lot of them had so much investigations like colonoscopy, endoscopy, trying to find the reason for this pain. And I think we are still not sure of what can COVID cause, and we are still learning and studying and researching.
نعم بالضبط. يعني هذه طبعا هناك عيادات متخصصة for long COVID. هل يوجد عيادات متخصصة للإندومتريوسيس يعني في كل مدينة من مدن بريطانيا؟
Yes.
ممتاز. هل أكو waiting list للموضوع؟
It is, because obviously it's a specialized clinic. So the waiting list can be slightly longer than just a general clinic. So for example, we have a center at UCLH where I work. And, we see these patients as a multidisciplinary team. So we have special gynecologists special skilled gynecologists who deals with treatment while endometriosis. And we have a special skilled gynecologist who do ultrasound or mapping endometriosis, and we work together. And obviously there is the colorectal bowel surgeon, there is a urologist. فيعني all these sometimes are needed to treat these women. So that's why it's not a very simple, straightforward condition to be treated. That's why these specialized centers are really, really important.
بالتأكيد. طيب أنا عندي سؤال من كلية طب البصرة. الدكتورة زبيدة تقول thank you very much for this information. Is large chocolate cyst has a high risk to rupture? And what are the causes of rupture? And I want to know يستمر السؤال أعتقد about the treatment. I want to know if the ovary is destroyed by the cyst or not.
So what is unique about chocolate cysts, they are deep in the ovary. They originate from the ovarian tissue, and the capsule, we call it, is thick. So they don't easily rupture like other cysts. But because they are deep and they invade the kind of the ovarian tissue, depending on the size, الحجم الcyst, obviously the bigger the cyst, the more damaging effect is to the ovary. But because these cysts are a different type of cyst than the other cysts that we see, their effect can be more destroying to the ovary.
نعم شكرا جزيلا. طبعا احنا عندنا بعد وقت، الأخوة والأخوات إذا عندهم أي سؤال يقدرون على الشات أو سؤال مباشر مع الدكتورة غادة. أستمر أنا في أسئلتي الحقيقة حول هذا الموضوع. الإخوان إذا عندهم سؤال يقدر. عندك يا دكتور مصطفى البدران من السويد. تفضل أخي دكتور مصطفى.
شكرا جزيلا دكتور عامر. شكرا دكتورة غادة على المحاضرة الحلوة. يعني يجوز هي شوية basic بس I'm a consultant neurologist in Sweden, and I have one question regarding the robot surgery. I mean, what is your information or experience about the neurological complication, pain, mostly pain after the robot surgery of the endometriosis?
After robotic surgery, you mean?
Yes, I have a patient who was in London, I think, yes. And after robot surgery, it was attend the gastroenterologist, the physician, not the surgeon. And the pain in the abdomen and the leg, one side, I think, the left side. And he sent the patient to me. I did not find any objective sign and symptom. So I'm thinking to send her to neurophysiological examination, because as you said, the pain. So do you have any experience about the neurological complication after the robot surgery of the endometriosis? Thank you very much.
Thank you so much. Thank you. I think the neurological component, it is partly because of the disease itself. and the endometriotic tissue, growing in different parts of the pelvis or the abdomen, but also it could be a result of the surgery, and any surgery. It does not relate to robotic surgery as such, but it could be related to the, a laparoscopic surgery, could be related to the open surgery. So whether it's the effect of the surgery, the effect of the position of the patient during surgery, or defect to the adhesions or the scar tissue that happens after surgery. So it is really difficult to say why, it happens, but it could be multifactorial rather than just one thing, and is not related to robot. So robot is just an alternative way of treating these women by surgery, but it shouldn't cause any different complications to laparoscopy or even.
طيب شكرا. Thank you very much. عندنا سؤال وأرجع إلى دكتورة زبيدة بعد قليل، ولكن عندي سؤال من مستر سلام موسى، الأخ الدكتور سلام، واحد من الجراحين العراقيين الماهرين في كيترينج، ويسأل يقول: Thanks for this lecture. Endometriosis is variant in its degree. Early diagnosis may be better and lead to easier control. Is there any screening for high incidence in the community?
Yeah, a very, very important question. Unfortunately, there is no screening. So like with other conditions, there is no screening as such. But early diagnosis is very important. And the best way for early diagnosis is for having the awareness that this condition is there, and that certain symptoms can relate to endometriosis. The diagnosis can be as easy as by ultrasound. If you have a specialist gynecologist or radiologist who've got special skills in diagnosing endometriosis by ultrasound. MRI can be used, simple diagnostic laparoscopy can be used. So it's not screening as such, but I think once we know that there are symptoms, we need to investigate and we need to get the diagnosis correct.
Right, thank you very much for this clarification. Now, دكتورة زبيدة من كلية طب البصرة، هل أنت معنا لا زلتي؟ تفضلي.
مرحبا دكتور، شكرا جزيلا على الموضوع. العفو، كنت أريد أسأل دكتورة غادة بخصوص الشوكليت سيست. يعني صراحة أنا واحدة من الناس اللي تعاني من هاي المرض، يعني وصار لي 5 أشهر من عرفت الدايجنوسيس مالتي. الشوكليت سيست هي بحوالي 7.5 إلى 6 سنتيمتر، يعني في 6 سنتيمتر أبعادها. عرفت من الMRI. فأنا أريد أعرف إنه بهذا الوضع يعني هل السيرجري اللي هي لابروسكوبيك سيرجري available بهاي الحالة، لأن الحجم مال السيست كبير، وهل إنه السيرجري هي أحسن الحلول بهاي الوضع، ولا يعني أستمر على الكونسرفاتيف ميثود، مع إنه الكونسرفاتيف ما جاي تفيدني، يعني أكو بين وأكو أكثر شيء urological symptom أكثر من menstrual symptoms.
No, thank you so much for sharing this. طبعا it is, as you said, it's your symptoms and what's controlling your symptoms. If the conservative management or medical hormonal treatment is such as GnRH, progesterone treatment, if they are helping in controlling your symptoms, then you can continue with conservative or medical treatment. If they are not helping or not controlling your symptoms, then yes, surgery is the option or the next option. And laparoscopy definitely can be done. Most of the time you are not able to remove the cyst completely, so that what they do, they call it de-roofing, so they open the cyst and they drain all the chocolate and try to cauterize the area, because as we said, it's not a normal cyst, it's just kind of invades in the tissue of the ovary. But again, depends on your fertility plans, on your pain. So it's a discussion of your choice, your option, and your symptoms, and what are the benefits and what are the risks. But if you're asking me, is laparoscopy possible? Yes, it is possible. No. Is conservative treatment possible? Still possible.
No.
Okay, thank you very much.
Thank you.
أهلا وسهلا، شكرا دكتورة زبيدة. ومعي دكتورة يسرى طاهر جرجيس من الموصل. تفضلي دكتورة يسرى.
ألو مرحبا.
أهلا ومرحبا، تفضلي.
نعم دكتورة، طبعا أنا أشكرك على المحاضرة، بس يعني أنت قلتي early diagnosis يعني ultrasound expert in this condition. هو أكو يعني فد شيء ما عدا الأوفيريان سيست، يعني أكو ultrasound findings يعني اندومتريوسس مثلا موجود باليوتروساكرال مثلا.
Yes.
يعني
Yes,
نقدر نشخصه يعني بالالتراساوند.
Absolutely.
شلون يعني؟
But it needs yes, it needs a very it's a training and the special skills. So I can't say that all radiologists or gynecologists who are able to scan are able to diagnose endometriosis. It's a very specialized area.
نعم. إذا عندك صور مثلا تبعثيها.
Of course, yeah. يعني I showed one picture كانت مال bowel endometriosis. So for example, in our center, we scan women with endometriosis, and we scan all women, and we can see as early as mild endometriosis if you know what to look for and where to look for. So we can see endometriotic spots, nodules, in the uterosacral and the rectovaginal. You can see it under the ovaries. You can see it in the bowel. You can see and what it's a training. It's a training, and you need to be kind of trained by a specialist who is experienced in endometriosis scanning. So it's not everywhere. I agree with you, but it's a training and skills.
نعم. طيب شكرا جزيلا. نعم تفضلي دكتورة إفراط، تفضلي.
إذا بدون زحمة، إذا عندك مثلا صور يعني إذا تنزليها على الجروب اللي نحن يعني اللي وصل الإعلان. أولاً. ثانياً يعني إذا أنت عندك mild endometriosis أنت قلتي I will treat to stop the progress of the condition. يعني مثلاً يعني نعالج بcontraceptive مثلاً لو يعني بس يعني إيش هو الراديكال treatment.
نعم. So again it depends يعني على الأعراض.
دي يتقطع دكتورة غادة.
نعم.
تفضلي.
يعني it depends on the symptoms. So يعني على الأعراض. So if some women have no symptoms at all, okay, that's one thing. If they have severe symptoms, that's another thing. But also on their fertility. يعني that someone is wishing to get pregnant is different from someone, let's say, who doesn't want to get pregnant. So most of the time, obviously, it's analgesia, but it's hormonal treatment because the hormone suppresses the endometrium. Routinely Mirena coil or a progesterone container, because it helps with the pain, helping the endometrium. Also, progesterone-only pills. In more severe cases, not in simple cases, you can go even further for GnRH, especially prior to procedure or even to continue for months. So it really depends. But for most mild cases, is hormonal treatment. Usually will help with the symptoms and suppress the endometriosis.
نعم. نعم.
السؤال.
نعم تفضلي.
كان وي اسبايريت ده ما أعرف الحقيقة يعني ممكن أكمل له إذا أكو
نعم تفضلي.
فكان وي اسبايريت the cyst or يعني and then give a treatment لو إلا لازم سيرجري.
لا ما في
يعني
not only surgery. On the yeah, it depends on the symptoms, on the size of the cyst, you know, on the in general, you know, what the patient is choice, you know, whether she wants to get pregnant or not. So there are so many factors, but the cyst, we not always surgery. So usually, for example, we don't offer surgery unless the cyst is big, let's say more than 5 centimeters. Okay, so if smaller cysts, you know, and patient is not symptomatic, you know, we can leave it. We can continue with conservative or hormonal treatment. Aspiration, you know, you can aspirate, but the thing that it will recollect very quickly. So, you know, yes, you can do it in certain cases, but it's mainly, you know, hormonal treatment, suppressing endometriosis, and surgery to try and remove as much as possible of the cyst and cauterize the base so it doesn't recollect as quick, because if you do aspiration, it will usually collect very quick.
نعم. طيب شكرا جزيلا. شكرا للسائلة وشكرا لك دكتورة غادة. عندي أيضا سؤال أو مداخلة أعتقد من دكتورة مي بني إذا موجودة معنا. تتفضل دكتورة مي. نعم تفضلي.
Thank you, Dr. غادة, for the nice talk, and you covered the subject from all its aspects. I just wanted to add that it's extremely important that the doctor keeps all gynecologists and health specialists to keep endometriosis in mind. All patients, because when you have it in mind, then you can reach the diagnosis easier and quicker, especially when we have all the diagnostic tools of ultrasound centers. Because we notice that lots of patients can really get pushed one way or another in different treatment schedules too far away from achieving the goal. Thank you very much for the really nice talk.
Thank you so much, much appreciated. And I completely agree with you. It's about awareness. And that's why we are all here, is to increase the awareness for everyone. So for public, for family, for doctors, you know, that endometriosis is a true condition. It's a painful chronic condition. And the quicker we can diagnose it, the quicker we can treat these women and help them with their symptoms and their suffering. So definitely, I completely agree with you. Thank you.
طيب شكرا دكتورة مي والدكتورة غادة على الإجابة. عندي سؤال من دكتور عبد الرحمن توفيق وأرجع الدكتور سلام in a minute. دكتور عبد الرحمن يسأل, does contraceptive medications used in a treatment and for how long should be used?
Yes, it's a good question. Yes, you can use it. Again, it depends because you are stabilizing the hormones. So we try again to stabilize or suppress the endometriosis. How long it can be used? It can be used for months, can be used for years, depending on, you know, patient symptoms and wish, you know, whether to get pregnant or not. So it's one option. Yes.
نعم بالتأكيد. إذن أعتقد دكتور عبد الرحمن توفيق معنا الآن. تفضل عبد الرحمن.
السلام عليكم. شكرا دكتور عامر وشكرا دكتور غادة. محاضرة حلوة جدا ورائعة. عندي سؤال آخر. If you do cautery to the ovary, دكتورة غادة طبعا السؤال. If you do cautery to the ovarian cyst, you may likely to damage the ovary. Then why don't you do oophorectomy if it is unilateral cyst?
Good question. يعني إحنا we try to keep the ovarian tissue as much as possible because, you know, endometriosis can destroy ovaries, and if it happens in one ovary, it can happen in the other ovary. So if the woman is, you know, towards the end of her reproductive years, she doesn't want to get pregnant, or if the cyst is so big that is damaging the whole ovary, then, you know, definitely it's an option to remove the ovary. But we have to look about the size, about the patient herself, you know, what she wants, her age, her fertility. So there are so many things that goes around it. And endometriosis itself, the cyst itself can damage the ovary. So you are trying to help, but rather than doing more damage. But, you know, it's all these options. It depends on what the woman wants and her symptoms and her fertility.
Thank you.
شكرا أخي دكتور عبد الرحمن. إذن أرجع إلى الدكتور سلام موسى. تفضل دكتور سلام.
Thank you very much, Dr. Amr. Thank you, Dr. Ghada, for you know, this nice lecture. I got, you know, one comment, and the other one is a question to you actually. Is the comment that honestly is, I don't know, but I believe I'm a general surgeon originally. I believe that endometriosis sometimes is worse than a malignancy because you will find it everywhere. And I remember my nightmares is when you open for intestinal obstruction and you find everywhere, you know, the bowel, and that's a problem by itself.
Yeah.
But and that is why I think in this case it's better to be treated conservatively, avoid surgery, because once you go in, then you will go in and in and in, and it will be a nightmare for the patient. Now, regarding my question is that while you are treating, you know, the things with the, you know, hormones, you know, to suppress, I think we, you know, from my specialty breast, I saw some cases regarding the cases of infertility, treatment with hormones. There's an increased incidence of breast cancer. But I don't know about endometriosis. From your experience, do you think that this affects the incidence of breast cancer or not? I don't have such figure.
Yes, you are right. So first of all, thank you so much. So first of all is, you know, the options of conservative, medical, and surgical is that. And as I explained before, it all depends on the severity of the disease, on the symptoms of the woman and her fertility wish, as well as the skill of the surgeon. So it's usually, if a surgery is done, it's not easy. And that's why it's done in a multidisciplinary team by different specialties, because it can be very difficult and very serious. But sometimes there is no option because conservative or medical is not helping and she needs surgery. So surgery is always an option if we can't help with either medical or conservative. In terms of treatment with hormones, so it's a hormonal treatment. So as we know, with hormone treatment, there is increased risk. And it is as with any other treatment. So treating, using contraception, using HRT, using progesterone for other things. So it is a risk, and we obviously, that needs to be as well, acknowledged and discussed with the patient, and as well as looking into her family and risk factors. So whether the woman has higher risk factors of cancer or not, she's got a family history or not. So it's as I said, it's not one thing, it's a complex condition. So we have to look into the aspects of it from different angles. But yes, hormonal treatment has got risks.
Thank you very much. Thank you, Salam. Now the أكو question من السؤال من هناء حسن. What is the reason for the early menopause?
What is the reason for early menopause?
Yes.
As you mean in relation to endometriosis or just the general question?
يعني أعتقد general بس ممكن ناخذه من جانب الendometriosis يعني أيضا.
Okay, so I don't think there's any clear evidence relating early menopause to endometriosis, but early menopause can have so many causes. Whether it's relating to the medical condition, whether it's related to the ovary itself, whether it's related to the pituitary, to the brain. So there are so many reasons. So I don't think there is only one reason to tell here, or one is a simple answer. I think it's more complex than that. But we can look into menopause and other signs and symptoms and causes in another lecture. I'm very happy to do that.
نعم. شكرا جزيلا. شكرا لك وللمحاضرة والتواصل معنا إن شاء الله في مستقبل المحاضرات، لأنه كثير من القضايا لا تزال بحاجة إلى التثقيف حولها في مواضيع الطب النسائية صراحة. وإحنا يعني صرنا نستضيفك مرة أخرى إن شاء الله في المستقبل القريب. وتشكرات أيضا كثيرة من الأخوة والأخوات الموجودين معنا في هذا المنتدى في هذه المحاضرة. وخاصة الآن عندنا شكر من طبيبة من الفرات الأوسط، جامعة الفرات الأوسط في النجف الأشرف في العراق. طيب شكرا جزيلا دكتورة غادة، وشكرا للحضور الكرام. نلتقيكم إن شاء الله الأسبوع المقبل في محاضرة لطبيب عراقي استشاري في طب الطوارئ، وهو يتحدث عن الشيخوخة الخضراء وكيف نعمر بسعادة كما يقال. شكرا جزيلا لحضوركم، وشكرا دكتورة غادة مرة أخرى.
شكرا جزيلا، تشرفت بحضوري وبمعرفة الجميع. شكرا جزيلا and it's my pleasure to be here and to come again. Thank you so much.
الله شكرا.
Thank you.
السلامة.
Thank you. مع السلامة. Thank you.
Beautiful.
Very nice. It's our pleasure. Beautiful lecture, Dr. Awad. It was absolutely marvelous.
شكرا. بارك الله بك. نعم.
Thank you.
شكرا.